guide to this session with thoughtful insight and direction. We have Ms. Dhruti Mahant ma'am, Principal of Let R.P. Patel Nursing College, Ode, Anand.
Everyone, please be seated. Ma'am will be here with us shortly. Thank you for your patience and cooperation. Extensive academic and research experience. Ma'am holds a BSc and MSc in nursing and is currently pursuing a PhD from Sumandip University. She has conducted and published multiple research studies focusing on health education, open toileting awareness, and nutritional interventions among adolescents. Ma'am has strong professional experience, having served as an ICU nurse, staff nurse, nursing tutor, and currently as in charge principal cum assistant professor. Ma'am has actively participated in over dozens of national and international conferences and workshops, strengthening her expertise in teaching, research, and healthcare innovation. Ma'am is a Senate member of Sardar Patel University, a member of SOCHNI and SOMI, and has contributed to curriculum development, book writing, and NGO activities. Ma'am has also organized an advanced critical care nursing workshop and served as a moderator in webinars focused on brain health and stroke prevention. And with that, I hand over the session to you, ma'am, Ms. Dhruti Mahant, ma'am. Please take us forward.
This important session is chaired by a widely respected leader in nursing education, Ms. Indravati Rao ma'am, Principal of Government College of Nursing, Surat. Ma'am, we welcome you to the stage. Please join us on the stage.
For your kind word. Namaste and good afternoon. As you all know, this is the time for the lunch, but just bear for us for the next half an hour. So, it's my honor to chair this significant session. The session is very much critical issues, evolving session and the burning session, that is addressing gender-specific health needs, equal access to health care for all genders. In today's healthcare landscape, equitable access is not merely an aspiration, but it is necessities. This topic calls for an inclusive, right-based approach to healthcare, one that not only addresses biological differences, but also respond to social, cultural, and systematic barriers faced by people across the gender spectrum. Our session aims to shed light on these disparities and explore inclusive strategies that respond to the unique health needs for all genders, ensuring dignity and quality in care delivery. To give my more insight on this topic, it's my privilege to introduce Dr. Ramya K.R. She is currently serving as an assistant professor at RAK College of Nursing, UAE. She holds a PhD in medical surgical nursing and is an esteemed alumni of AIMS New Delhi. With over 12 years of teaching experience across postgraduate, undergraduate, and diploma nursing program, she brings a wealth of academic and clinical knowledge. Dr. Ramya has also held key leadership roles in healthcare quality management, including coordinating multiple NABH accreditation. She served as the lead of the quality cell in a 1600-bed tertiary care hospital and has also taken on the responsibilities of a nursing superintendent. An accomplished researcher, Dr. Ramya has numerous national and international publications to her credit. She is a member of editorial board and serves as a peer reviewer for various index journals. a recognized resource person. She has been invited to speak at several national and international conferences and workshops. She has successfully led and implemented various healthcare quality improvement initiatives. So please give a big round of applause to Dr. Ramya, and I'm welcoming to Dr. Ramya, and now this platform is yours. Please, Dr. Ramya.
Thank you so much, ma'am, for your kind and generous introduction. I hope I am audible to all. Okay. As Dr. Indra, I hope I am audible. Can I get a thumbs up if I am audible? So, as Dr. Indrawati rightly said, the topic I am allotted is addressing gender-specific health needs and providing or ensuring equal access to healthcare across all genders. I know, as she rightly said, this is the need of the hour. It has become a mandatory thing to have a sustainable development across the world, including in India. So it's a very huge and vast topic, and my duty, I won't be able to do cover so much, but I think I can share why we all need to look into the gender perspective when we provide care. And I hope that when you go home after this, you realize the importance of providing care from the angle of gender. So, sustainable development across the world requires universal health care to all people. So, what I mean by universal health coverage? It means all people, regardless of gender, income, background, have access to quality health services without suffering financial hardship. So, without the cost, worrying about the cost, irrespective of the gender, income, background, they should have access to healthcare services. Why? Because if we can provide the access to universal health coverage for all, we can significantly impact the health and lifestyle of people in a sustainable way, thereby promoting the health and well-being of the population as a whole. We are not talking about the general or high-risk people. We are talking about the population as a whole. Then only the sustainable development of nation will happen. We need some population strategies to elevate improve the outcomes. Now, why specifically gender? Why we need just include the gender specifically? We all know gender and sex are two interlinked things. And why is it important to consider sex and gender in health and healthcare? So, sex refers to a person's biological characteristics, which is influenced by one's genetics and hormones, and the role of lifestyle also comes into play. Then, women have, why do we need to have some sex-specific or gender-specific perspective in health and healthcare? Women have unique physiology and response to the therapeutic interventions. And it's often significantly different from that of men because of the genetic and hormonal influences. Now, how sex is different from gender? Or how both are different from each other? Gender is about the characteristics associated with being a woman, man, girl, boy, or gender diverse person. It could be gender diverse. There are gender minority populations. So we are mainly the topic will be focused on major genders. So the gender, why gender is important for health and healthcare? Because gender characteristics are socially and culturally rooted, and they're constructed rather than fixed. And these gender norms, behaviors, and roles associated with the different genders vary across societies and cultures and can change. It is not constant, keep on changing. Now, why is it important to us as healthcare providers? First is the physiological and biological responses will be different based on the sex and the gender norms and the behaviors in the role can influence one's lifestyle and the way they respond and experience health and healthcare. So the ways in which, and in addition to that, we as healthcare workers, we may have some perspective in our mind and the ways in which researchers, as researchers, policymakers, and practitioners consider gender impacts how different symptoms are recognized and understood and how health conditions are diagnosed and treated. Now, this is just a pictorial diagram to put you into your mind that how gender and sex influences health and healthcare outcomes. Through genes and sex hormones, the characteristics of gender is displayed. And no, not the gender, the sex is displayed. The gender is influenced by lifestyle, the nutrition. So the society has a major role in shaping one's gender values, gender. But the sex and gender, they interplay, they interact each other. Now, why is it significant to us? Not just for us. Gender is a major determinant of health for women and men in India, like elsewhere. Everywhere it is. And health is significantly determined by biological, social, economic, and environmental factors like poverty, education, but those factors lie beyond healthcare. But we need to take care of those things when the people are coming to us. Now, what do we have to do as healthcare workers? We need to have a gender responsive healthcare. What do I mean by gender responsive healthcare? So, gender responsive healthcare, this is an evolving branch in healthcare, by the way. So, gender responsive healthcare is intentionally integrating the needs, the rights, the preferences, and the power relations among women, girls, men, and boys, and gender minority individuals, as well as across social, political, economic, and health systems in monitoring, treatment, and evaluation processes. So, if we are gender responsive, while giving vertical and horizontal equitable care, we need to bring gender perspective into that. So, how we go ahead with that? So, the first and foremost important thing is to understand that, there is a gender disparity exists in the way that healthcare is delivered across genders. And when we say gender disparities, we commonly focus on women. Why? It's because women are disproportionately affected and they face higher disparities. Not that, but we'll cover the other aspect as well, the other gender aspect as well in the coming slides. But women are disproportionately affected and they face higher disparities. This is as per the statistics. So, women lag behind men in many areas. I'm sorry. Oh. Hello, ma'am. Is everything all right? Yeah.
Ma'am, it's a request
I
to
got
adjust
stuck
your
in
camera.
Dravadi back.
Ma'am.
By mistake?
No, it's a now it's okay. Now it's okay.
Okay. Oh, you couldn't see me. I was not watching my screen. Yeah. Okay. Thank you.
Yeah.
Thank you so much. Okay. Yeah. Okay. Yeah. So now, the first step in implementing or the gender responsive care is to understand the extent of which the problems women and the men face in the healthcare. And we focus on women because we'll see some statistics why we are talking about or why we need to focus more on women and the people who face more disparities. Because it seems that women lag behind men in many areas of health and well-being. Though the women have more life expectancy, the quality of life and the well-being index may be low in women in many areas. And it seems that women have lesser access to mass media and literacy, and at times they spend more time in unpaid care and work than men. They are more vulnerable and they're exposed to some specific risk factors. That risk factor is unique. And there is a disparity in the household level. The people we invest in the nutrition, care, and education. There is a disparity in the household level between in these areas. And access to and use of health services. Women have limited access or restricted, not limited, I could say restricted or access to and use of healthcare services, even if it is available. And the way women experience healthcare is different. And the social impact of ill health is different across genders. Now, there are some statistics. If I could convince you in this 30 minutes why we should focus on women, regardless of their status and from where they are coming, regardless of their other variables, if you could focus on vertical care, we can significantly improve the patient outcomes, population outcomes, and the economic of our country. Our GDP is going high. The current health expenditure is going high. But the number says that the expenditure goes high, not necessarily mean that we are investing more health expenditure for the women. No. It says that the statistic says that the current health expenditure and the catastrophic health expenditure goes high. We spend less money for the health of the women. And we, as Indians, we prefer men because the sex ratio is 105 now. This is an little old statistic. The recent statistic says 105. Maybe the community people, right now the people who are focusing in India can correct me if I am wrong. We have 105 to 100 males per 100 females. This is sex ratio at birth. So we have more males. And out of that, only about 6 in 10 married women in India says that they are alone or jointly make a major household decision. So this says that they don't have a say in their health and healthcare decision makings. And over the years, the number of girls who complete the primary education goes higher and higher every year. It's a very good, but girls comprise only about 2 in every 5 science, technology, engineering, and mathematics graduates. So they are not completing the higher education levels. And they are underrepresented in the higher education. The same in the workforce. The women's labor force participation is about 3.5 times lower than that for the men. And this gap has persisted over time. And though they are not the labor force, they are involved in a lot of unpaid and unrecognized work. And we'll come to know, in the later slides, we will see why this is important. And coming to the access to the internet and the mass media, less than half as many women as men use internet. So they have less access. Slightly over half as many women as men own mobile phones in India. And though almost the same, the proportion of children engaged in child labor is slightly higher among girls. And 3 in 4 women own a bank account in India. So financial, we know how healthcare outcomes, our patient outcomes are connected to cost. So 3 in 4 women own a bank account. I'm just talking about the bank account. And women in India are estimated to earn only about $2 for every $10 earned by men. So there is significant financial or decision disparities and other disparities exist. And coming to the leadership position, including in the recently 2 days back, I read a survey in the healthcare, not just in other sectors. There are less, even in the medical council, nursing council, pharmacy council, everywhere, the women leadership is less. The Indian women spent nearly 10 times as much as time in unpaid domestic services, over 3 times as much in unpaid caregiving services men. So, if we utilize, they are underutilized, or they spend a lot of time in unrecognized domestic services. And about 2.3% of households in India are now located more than half an hour from water source, and it's a major. It has also major implications. Regardless of this, women have better life expectancy than men. So, if the women don't have the opportunity to take care of their health and well-being in their productive years, as their life expectancy is more, the quality of life is going to be poor for them, and the financial and the social and the cultural barriers that prevent them in seeking health care may exacerbate or worsen the clinical conditions, and they will have a poor outcomes and poor quality of life. Now, look at the medical conditions. The top 10 cause of death among men and women. Ischemic heart disease tops the both. But as someone who is specialized in cardiological nursing, I can say that. I'm sure you must have felt that. We have very limited evidence regarding how different genders present with the ischemic heart disease, how different genders respond to the treatments. I had a lot of studies, last month I was reviewing a lot of studies, and we see that the men and women respond differently to thrombolytic therapy and even antiplatelet therapy. The incidence of complications are different, but we have very limited data on all these things because the research has been focusing on men, and we have limited participation of women in the research and evidence synthesis. Let's look at the second one, chronic obstructive pulmonary disease. The risk factors of chronic COPD might be different in men and women. In women, they are more exposed to household air pollution or from closed spaces, okay? And in men, it could be the smoking or other outdoor air pollution. Coming to the stroke, and in women, the lower respiratory infections ranks the third. Now the stroke, ranks the fourth in women, third in men. The major differences here are the road injuries, road traffic accidents, and cirrhosis of liver are among the top 10 leading causes of death, and barely lowest among men, but not among women. But in the women, you see the diabetes and falls feature the 10 leading cause of death among women, but not among men. India is known as the diabetic capital of the world. So, women are disproportionately affected. The complications of diabetes have long lasting. We have more life expectancy among women. So these are the things we must understand. We must give horizontal care. It must be accessible to all. But when we start looking at the specific case, we must be able to provide the vertical care. I think that's where we are lacking in India. And not just in India, everywhere. So we can clearly, I think, I don't want to spend so much time here. So we can say that, even the incidence and the prevalence of disease and the daily, the top common causes of morbidity and mortality is different across genders. Again, the under-5 mortality rate by sex is different. But why? See, the mortality, why I'm bringing this? Recently we could bring down the mortality rate significantly among both genders, especially in females. But what we have seen that the residents, the education, the age of residents being rural, and the education of mothers, the low the education of mothers, the mortality rate is high. That is why we need to, in the primary health centers and community health centers, we need to focus more on these aspects. So look into, other than the major diagnosis or the major primary problem, we need to look into these variables if you want to have a sustainable development and to improve the progress of your nation. And though we could bring down the total fertility rate, again the same like the mortality rate, this under 5 mortality rate, it is significantly influenced by the educational level of the mother or the women. Now coming to the overweight and obesity prevalence, the adults. First we'll see the adults. See, females are disproportionately affected when the prevalence of overweight and obesity is higher among adult females. It might be a little different in adolescent age, but it's higher among women. And coming to reproductive health needs, fewer than 1 in every 5 adolescent girls in India has comprehensive knowledge about HIV and AIDS. So there is restricted or limited access to reproductive health needs for the women and the girls. And gender-based violence itself is a big topic to discuss. More than 1 in 3 women in India experience intimate partner violence in their lifetime, with the rural and uneducated women and those from the poorest households facing significantly higher risk. And again the same, there is socioeconomic and the area-wise disparities exist in this matter. The risk factors like alcohol consumption, the tobacco smoking are higher among men, but women and girls are exposed to household smoke from fuels. So indoor air pollution is more among women. Again, coming to the antenatal and reproductive health services, the disparity exists in terms of gender, not just in terms of gender, it exists in terms of education as well. So educating and providing awareness and information at the level of, in these areas can significantly improve the outcomes here. We discussed the diabetes before. Diabetes is gender-wise or sex-wise, it is more prevalent among Indian women than men. Another disturbing factor here is not just the prevalence is high, most of them are undiagnosed and they are untreated or poorly controlled, both diabetes and hypertension. Though the government has made many insurance schemes, and these days there are, regardless of whether it is out-of-pocket expenditure or health insurance coverage, it's less utilized for the women. It's less utilized. The amount is less utilized for the women. Not just the amount, even the enrollment is less by the women. So if I could give you an insight and throw some light on how huge the problem is, or how an iceberg is, that would be the takeaway point for this. Then, so ensuring equal access to health can lead to a healthier and more productive population. Not just access. Ensuring access will not solve the problem. We need to recognize and respond to the unique healthcare requirements of different genders, including men, women, and gender minorities, to improve the economic growth of the nation. What are the major barriers to this? In short, there are socioeconomic barriers. It is a significant barrier limiting the access to healthcare for women, because when the resources are limited or scarce, The healthcare of men is being prioritized, leaving behind women and girls. And it is more pronounced in regions with inadequate healthcare facilities. Exacerbating these financial and post-related things, we have cultural and societal norms. Self-neglect and prioritizing family needs over their own health. It might lead to delayed or neglected medical treatment for the women. When I was a student, I have seen people coming to, but thank God these days cases. So sometimes it's the cultural and social norms or the self-neglect we need to address as nurses working in the field, regardless of whether it is a hospital setting or it's a community setting. And sometimes it's the stigma regarding reproductive health, especially for unmarried women and girls, prevent them from taking timely medical help. So this I think I have already discussed, because females suffer from accessibility gaps because of the cost involved in the healthcare. The subsidies are less utilized by the women or for the women. And if we could close the gender gap by addressing all these things, our economy of the country can significantly, the GDP can go significantly high. So it is a necessity, not an option now. So this is a framework, whatever I have discussed, it is here. So what are the social determinants of health inequalities and social determinants of health we need to focus when we provide, or if we want to address health and healthcare for gender diverse population or to meet the gender gap. So we need to look at the socioeconomic position, social class, education, occupation, income, the living situation. What are the behavioral and biological factors influencing each gender? The psychosocial factors underpinning each, the disease and the outcome. That's how we can improve the health and well-being of the population as a whole. Now, this is what I have been talking about. We are always worried about horizontal equity, I think, and we neglect the vertical equity in healthcare. So horizontal equity in healthcare ensures that individuals with similar health conditions receive equal treatment. We all agree. For example, both men and women with the coronary heart disease should have equal access to diagnosis and treatment, which requires public awareness of symptoms across genders. Many times, women think that last week I did a survey among general public here, and we realized that women don't perceive that they have a risk of getting heart attack or coronary heart disease. So we need to raise awareness. They have a good knowledge regarding coronary artery disease or coronary heart disease, but the risk perception is less. That's where our role comes. Now, vertical equity in healthcare. What is vertical equity? This is one area where in the field where we can work, regardless of the setting, whether it's a hospital or a community area. It involves tailoring healthcare services to meet the specific needs of different groups. Men require different types of care, different types of treatment. Women require different types of treatment. We should agree. We should understand. We should do that. This includes developing treatment protocol that consider the unique aspects of health issues faced by women and ensuring that guidelines are applied equitably. Now, the training and developmental needs for professionals. We very well know that there are training gaps. So, poorly prepared health workforce means extensive discrimination leading to thousands of Indian women missing out the needed health care. We need to equip our healthcare workers by some kind of gender sensitization programs. These days, a lot of programs are available online and on site as well. So offering insight into gender issues in healthcare to avoid gender biases, to make them understand how to tackle them.
Dr.
There.
Ramya, sorry to interrupt you. Just matter
Yeah, yeah.
because time is going, so next 2 minutes for you.
Yeah, sure. So the leadership opportunities for the women should be created more, including the healthcare. And we should create a better healthcare ecosystem in the community as well, especially in the community, because the reproductive health needs are to be tackled along with this. So this can be done by strengthening our primary and community healthcare systems. When we look at the primary, there are some tips I can give based on the recent evidences. We can initiate some grassroots initiatives. We can involve the NGO. We have a lot of digital health solutions these days. They can provide inclusive healthcare system based on the patient's needs. But all these requires the training and testing to be sustainable. These programs require to be tested. Then addressing gender bias in medical research. This is a very important area. We should, I think this is an evolving area these days. When we do clinical trials or studies, we should make sure women are represented very well. And it results in less effective, otherwise it will result in less effective healthcare for women. So we need to open more funding options for meeting the gender-specific needs. And these are some areas we need to focus. If you want to improve the reproductive healthcare access for women, we must focus on prevention and management of infertility, adolescent sexual and reproductive health. We must try to address the common healthcare problems, gender-based violence, safe motherhood. Here. So, at the community level, the approach will be more successful and sustainable if it is executed in a people-friendly manner and involve the NGOs, engage the leaders, and include telehealth services. So the takeaway message is that if you don't consider gender and sex in health and healthcare, you'll have insufficient evidence base to design health policy and healthcare. You will have a compromised quality and appropriateness of care. Delayed access to care, delayed diagnosis and misdiagnosis and neglect, increasing or escalating healthcare costs and catastrophic health expenditure. So, I just want you to, at the end, this is the last slide by the way, I think. So each one of us do a gender assessment. Are we gender unequal? In which level are we? Gender unequal? Gender blind? Are you gender sensitive? Are you gender specific? Or have you reached the level of gender transformative? So to conclude, the health systems are not gender, the health systems which are not gender responsive will fail. Gender inequality in healthcare affects women the most, making it hard for them to get the care they need. Providing health insurance alone is not enough to close the gender gap in healthcare. We need to address the cultural, societal, and economic barriers that prevent women from seeking medical help. And training for medical professionals need to include gender sensitivity to better address these issues. Thank you so much.
Thank you so much, Dr. Ramya, for giving thoughtful insight as the topic, and it is the fifth goal, gender equality. It is not possible to narrow down which topic is required at least 1 and 2 days to address, and that topic to narrow down and within a half an hour to explore it and beautifully justified your session. So thank you so much. to Dr. Ramya for giving or taking a wonderful session. Just one thing I would like to say that as it is the and we are discussing regarding the gender equality, somewhere if you will see our profession, historically it has been perceived that our profession is a female dominance, and somewhere our boys, our student, our male faculty, they are feeling that they are underprivileged, even though in the selection, in the recruitment criteria also, there is having some 5% and the 10% seat only reserved. So this is the high time we all have to, what we have this stereotype of the practice, that things is required to remove, and we have to develop resilient healthcare system. So that things is required. Now the SOCHNI is here, let's discuss on it, let's address this topic, and let that things is required to reach to our government so that that thing should not be happened. Thank you so much to CVM, SOCHNI, to given this platform to the Gujarat, and once again welcome you all to the Gujarat. Thank you so much.
Thank you so much, ma'am. Now it's time for the felicitation, and first of all, a warmly thank you to our respected session chairpersons and also the speaker. And for first most, I would like to invite Miss Ruti Mahant ma'am to kindly felicitate the ma'am as a mark of our heartfelt appreciation. I now kindly thank Bhaikaka University Karamsad to kindly felicitate Miss Ruti Mahant ma'am with token of appreciation with the memento and the certificate.
Thank you, ma'am. Now I may kindly request to Mrs. Chandrila Emmanuel ma'am to present a memento and certificate of appreciation to Dr. Esther Daniel ma'am, a token of our sincere thanks for her enlightening contribution in panel discussion. Thank you, ma'am. With sincere thanks, may I invite this certificate to Mrs. Chandrila Emmanuel ma'am for her graceful and thoughtful to this rich discussion. Thank you, sir. Thank you, ma'am.
Now it's time